Welcome, everybody. My name is Jason Howell. I'm Executive Director of Soberhood, which is a nonprofit here in Texas that oversees both Recovery People and the Texas Recovery-Oriented Housing Network. If you're registered for this webinar, you're interested in exploring the question, can federal dollars be used for recovery housing? And it's an important question because not everybody who wants to live in recovery housing has the ability to pay full price out of pocket. And so today we have Kristin Shilson, Joy Kearney, and Amy Pedersen from the Texas Department of State Health Services who will help us better understand one particular funding opportunity. Their presentation is chock full of information that will likely generate a lot of great questions. To prevent background noise, I have everybody except the presenters on mute. So if you're joining us via the web browser, please type in your questions in the chat box. The chat box is going to be in the lower right-hand side. And if you're not able to join us in the browser for whatever reason, you can always email your questions to jason.howell@soberhood.org, or you can even text me questions at 512-466-1381. At the end of the presentation, we'll get to your questions and to your comments. And if we can't get to them, then don't worry, we'll be answering those via email later on this week. So without further delay, I am happy to turn this over to Kristin, Joy, and Amy.
Great, thanks, Jason. I'm going to turn it over to Joy, who's going to give a little bit of background about the program.
Hi, good morning, everyone. Thanks for joining us. We're excited to be speaking with you today about the Home and Community-Based Services Adult Mental Health Program. Sorry, we're just trying to get to the next slide here. So while we're having some technical difficulty, just to let you know that the Home and Community-Based Services Adult Mental Health Program is the first home and community-based program that has been formally approved by Center for Medicare and Medicaid Services for adults with mental health needs in Texas. So we're really excited about that and just share the information. So that formal approval that we received from Center for Medicare and Medicaid Services is that we received that approval under the 1959 Social Security Act. So we are a 1959 state plan amendment, and it gives us formal approval to provide home and community-based services to adults that have resided long-term in mental health facilities. I'm going to speak a little bit about several different target populations this morning, but this is the group that we are currently approved under the state plan amendment, so I wanted to give a little bit of information on that piece first. I'm sorry, Kristin.
Just roll it. Oh, just roll it.
Okay. Okay. So with that in mind, also we do have an expansion to our program. So we received legislative direction through this past session through the 84th legislature in House Bill 1, Rider 61B, to expand home and community-based services to divert populations with serious mental illness from jails and emergency departments into community treatment programs. And so that's what the team here at DHHS has been working very diligently to do, is to work towards an amendment to the current approved state plan amendment to include the adults with serious mental illness, frequent arrests, or frequent emergency department visits, which is a large portion of why we're reaching out to different housing providers, community providers, because with this expansion population, we anticipate greater numbers of eligible individuals that would have a dual diagnosis and potentially could really benefit from some different housing options that many of you may provide or be connected with today. So as we are seeking the amendment to our current home and community-based services adult mental health state plan amendment, we will be running the expansion populations using general revenue. So we're going to get up and running in all populations. So we're accepting applications now for all three. But for the current approved population for long-term psychiatric hospitalization, we receive a federal matching funds for that population. And that's what we anticipate in the next year or so to receive for the expansion. But in the meantime, we're going to run the expansion using general revenue. So as the legislature directed us to expand to the frequently arrested and frequently having emergency department visits, they also appropriated funds for those. So we're going to use those funds to start serving those individuals that can really benefit from these additional supports. So in order to identify criteria that we will ask for in our amendment, we conducted a series of stakeholder meetings. And this slide just identifies the groups that we targeted or reached out to for stakeholder feedback. So local mental health authority, criminal justice community, advocates, private providers, managed care organizations, and also family members or potential beneficiaries or individuals that could be enrolled in the program and benefiting from this. So we reached out to the other jail diversion, emergency department diversion programs going on in the state and nationally, and also looked at kind of the data and the trends that were happening there to inform how we're going to structure this expansion of the program. So I want to dig into eligibility criteria. So I want to break it up. So I've been talking about the 3 different populations. So in order for an individual to be eligible, there are some overarching eligibility criteria. So first of all, everyone has to be an adult, 18 years of age or older, and they have to have a diagnosis of a serious mental illness. They have to be Medicaid eligible, meeting that financial threshold of 150% of the federal poverty level or below, and also meet a state-defined needs-based criteria. So as we go through the next slides, I'm going to run through what each of those markers are for long-term hospitalization, jail diversion, and emergency department diversion. But before I do, there's been several questions on how the state is defining serious mental illness for the purposes of the HCBS AMH program. So I wanted to take a minute to read over this definition. This is how it's defined in our state plan amendment that's been formally approved by CMS. So it's an illness, disease, disorder, or condition other than a sole diagnosis of epilepsy, dementia, substance use disorder, or intellectual or developmental disability that either A, substantially impairs an individual's thought, perception of reality, emotional process, development, or judgment, or B, grossly impairs an individual's behavior as demonstrated by recent disturbed behavior. So it is a program for mental health needs, but this is looking at someone could have a substance use disorder and then a co-occurring mental health disorder as well, just as long as it's not the sole diagnosis of the individual to participate in the program. So what you're seeing in front of you now is that criteria broken down per each population. So an individual would need to meet one of these 3 criteria I'm going to review to be eligible for referral to the program. So the first one is long-term psychiatric hospitalization. So the individual must be an adult, 18 years of age or older, with a diagnosis of serious mental illness, be Medicaid eligible, 150% of federal poverty level or below, and then during the 5 years prior to their referral, they had to have resided 3 or more cumulative or consecutive years in an inpatient psychiatric hospital. So that means that it could be one long stay for 3 years, or over the 5-year period, they could have had several admissions to a psychiatric hospital that equal 3 years. And then the second one would be for jail diversion. So that's an individual must be 18 years of age or older with a diagnosis of serious mental illness. For this, they have to have an active Medicaid benefit. Their Medicaid has to be active at the time that they're referred. That's just different than the first criteria that they're just showing that they're Medicaid eligible. The reason that we have that difference is a lot of people coming out of the hospital do not currently have their Medicaid active at the time that they're coming out of a long-term psychiatric hospitalization. So jumping back to 2, that they have an active Medicaid benefit, they meet financial eligibility, the 150% of the federal poverty level or below, and then looking at 3 years prior to their referral, that they have 2 or more psychiatric crises. And the way the state's defining that is that it's either an inpatient psychiatric hospitalization and or crisis episodes that require outpatient mental health treatment, and 3 or more arrests. So over the 3-year period, they have 3 or more arrests in combination with 2 or more psychiatric crises. So it could be 2 psychiatric hospitalizations 2 outpatient crisis episodes, or 1 inpatient hospitalization and 1 outpatient crisis episode. So any combination of that with the 3 arrests over the 3-year period would indicate someone would be eligible for the jail diversion. And then for the last target populations, our emergency department diversions. So again, it has to be an adult, 18 years of age or older with a diagnosis of a serious mental illness, have an active Medicaid benefit, financial eligibility, 150% of federal poverty level or below, and then during the 3 years prior to their referral, have a history of psychiatric crisis. So it's defined the same way as it is in the jail diversion, either an inpatient psychiatric hospitalization or an outpatient mental health crisis episode, and 15 or more total emergency department visits over 3 years. And those 15 visits don't have to have a sole diagnosis for a mental health need for that emergency department visit. There just has to be a total of 15 in combination with the psychiatric crises and those other 3 indicators to determine if someone can be eligible for referral. So providers that contract with DSHS will be able to choose which of the 3 populations they can safely and successfully serve in the community. A provider can choose 1 population, 2, or all 3, depending on what their resources are in the community to support individuals. I'm going to go through referral and enrollment. So an individual can be referred either from the state hospital or from the local mental health authority, and that depends on where the individual is residing at the time they're referred. So some individuals may be in the state hospital system, and we've worked with all the state hospitals to train them on the referral process. So the referral would be initiated from the state hospital staff. And then any individual residing in the community would be referred from the local mental health authority. And so we've worked with the local mental health authority on what that process would look like. So if you have someone identified in your area that meets this criteria, we'd ask that you contact the LMHA so that we have a streamlined referral approach, and they are familiar with the forms and the consent to have an individual referred and assessed for the program. So once the individual is referred, we conduct an independent evaluation that looks at that they meet one of those 3 initial criteria, that they can benefit from the services and supports that are offered through the HCBS AMH program, and that they meet functional and financial eligibility. And then individuals that are determined eligible will be enrolled by DSHS. This is a quick snapshot of kind of the flow. So they meet the initial eligibility. The referral comes in either from the state hospital or the LMHA. DSHS reviews the referral form. Then we schedule an independent assessment for that uniform assessment, assess financial eligibility, and then enrollment decision in the program. Individuals that are not eligible for enrollment are if they don't pass the functional and financial criteria, and then also if they're participating in another home and community-based program. So they can't be duly enrolled in 2 home and community-based programs. So this is a list of some of the ones that they could potentially be enrolled in. And if an individual meets the program eligibility for HCBS AMH and it's deemed that they can be clinically supported, so Amy's going to go over our service array in just a minute. There's a lot of similarities between some of the other home and community-based service waiver programs out there, but we do have a more robust array of mental health and substance use disorder services. So if it's clinically indicated that an individual could be supported more successfully through this program, we've worked with the other home and community-based programs to have a disenrollment process, and they can enroll into HCBS AMH. I'm going to pass it over to Amy Pedersen, our provider liaison, to review the HCBS AMH service array.
Thank you, and good morning, everybody. As Joy mentioned, I'm going to review the different services that are provided through the program, and as we go through these, I want you to kind of keep in mind that with this program, we have 19 separate services that are available for individuals that enroll in our program. And these services are really going to be individual to their needs. So an individual might come in and according to their goals and their needs based on their assessment, they might need 2 or 3 services, and other individuals might come in and need all 19 services. So it's really variable per individual enrolled. And with our services, they're designed so that they can be fully supported in the community and, achieve that successful tenure that many of them have never experienced. throughout their lives. So with these services, they're provided in the individual's chosen community. With this program, they get to choose which community they reside in, and of course that's going to be based on resources as well. So if there aren't any providers in the community that they choose, that's not going to be something that's applicable for them, or if they can't find a residential place setting in that community. So there would be considerations there, but also that these services are supported through the lifetime of the individual if clinically indicated and that individual chooses to participate for their lifetime. As this is a Medicaid program, and this is a state plan amendment, it's an entitlement program, so individuals that meet criteria, all the criteria that Joy went through, they are entitled to the services in this program for their lifetime. Okay, so now I'm going to review the services, and as I mentioned, we have 19 separate services, and I do have a brief overview of each service right here on the slides. And to just kind of keep in mind that, as the bottom of this slide says, that these are brief overviews and summaries, and they don't contain all the program requirements. So if you do want complete information on these, you can visit our webpage, which contains our provider manual and billing guidelines. So first, I'm going to review our residential-based services. And in our program, we do have 4 separate residential services that can be provided in the individual's choice of living environment. And the important thing to note that is that as this is a Medicaid program, it does not cover the individual's rent. That would be paid utilizing the individual's SSI benefits. But of our 4 residential-based services, we have host home companion care, supervised living, supported home living, and assisted living. And within those services, residential-based services could include things like help with daily living, such as medication oversight, bathing and dressing, chores or walking, and also maybe reinforcement of any specialized rehabilitative therapies they're receiving in the community. It could also include planning and cooking meals or helping them get involved with things that they like to do in the community. So keeping that in mind, I'm going to give you a little bit more information on what each residential service is. For the first one, we have host home companion care, and that would be provided in a private residence, either by a host home or a companion care provider who lives in that residence. So really, the type and frequency of supervision that would be needed, it would be determined on an individual basis based on the individuals residing within that home environment. The next one we have is supported home living, and that's going to be provided to individuals who are living in either their own home or apartment or a family residence. And that service could be 1 hour a day or more depending on the needs of the individual. So some individuals might need 1 or 2 hours every morning. Some might need 3 or 4 hours per day, depending on their needs. And it's important to note that with supported home living, it's intended to really support rather than replace their family and natural supports. We have supervised living, and that's our most intensive level of supervision for our residential-based services, and that's going to include 24-hour staff supervision, and that's going to be provided in settings. All of these settings have to be meet settings requirements, and with supervised living, that's going to be licensed or approved by the state of Texas. It could also be provided in a licensed assisted living facility that has no more than 4 beds, so that would be the caveat there. And with our supervised living, it could be provided in 2 separate ways. It could be provided by providers who are not awake during normal sleep hours, but they're present at the residence and can respond to the needs of the individuals during those normal sleep hours, or it can be provided by providers that are assigned on a shift schedule that includes at least 1 complete change of staff each day. So it really depends on the level of needs of the individuals residing within that supervised living setting. And then we have assisted living. So assisted living is, again, a 24-hour, includes 24-hour on-site response staff to meet those either scheduled or unpredictable needs of the individuals residing there. And it would be provided in settings that are licensed or approved by the state of Texas. And we have a specific licensure through the Department of Aging and Disability Services that we utilize. And I'm going to highlight, we do have a lot of services in here. We have psychosocial rehab, so that's going to be using any evidence-based interventions or evidence-informed interventions to help that individual maintain or develop skills that they need to be as independent as possible in the community. And some evidence-based practices could be cognitive adaptive therapy or seeking safety would be some examples. We also have employment services, so that's helping people obtain jobs of their choosing within the community. and that would be employment assistance, so helping them locate that job, and then supported employment would be helping them to sustain that job. We have minor home modification, so that's any physical adaptation to that individual's home that may be needed to ensure that they're safe and healthy, and as the program focuses on, really as independent as possible. We have home-delivered meals, so that's going to be provided to that individual 2 times per day, and these are nutritionally sound meals that are delivered to the individual's home. We have adaptive aids, so that would be any controls or devices or appliances that that individual would need to increase their abilities to maybe perform any activities of daily living or to perceive or communicate with their surroundings. And then we have transition assistance services, so that would be money that would be utilized to pay for any setup expenses that they would need when they're transitioning from an institution, such as a state hospital, into a community setting. So that could be furniture, linens, kitchen items. It could be deposits for first and last month's rent, deposits on utilities, such as those. We also have transportation services. So that's transportation that would help that individual access any activities or services or resources within their community as identified on their individual recovery plan. So if it's a goal of theirs, to increase, let's say, social skills, and part of that would be to attend some kind of support group or something like that, we could provide transportation to that individual to get to that support group. And it is also really important for these individuals, as it may be really difficult for them to either traverse a public transportation system, or they might be living in a rural or frontier area of Texas that does not have a public transportation system. We have community psychiatric supports and treatments, so that would be any therapy that that individual would be receiving, such as cognitive behavioral therapy, cognitive processing therapy, or dialectical behavioral therapy that would really be used for that individual to identify their goals and work on those goals and objectives. We have a standalone peer support service, and that's going to be provided by self-identified consumers who are in recovery from mental illness or substance use disorder. They have that lived experience, and they're trained by DSHS as certified peer specialists. We also have an ongoing chronic nursing service, so that would be for individuals that have maybe high needs diabetes care or renal failure. They might need ongoing wound care. So this would be really looking at those individuals that have chronic conditions that need, possibly daily or frequent nursing services to come in and assist them with that. It also covers any medication administration that that individual would need. We have substance abuse services, so those could be either individual or group counseling to really help that individual deal with any substance abuse or drug abuse issues. We have short-term respite care, and that's for individuals that would be living in their own home or actually living in their family home. And that would be utilized if that family member needed to go out of town or be away from the home for either a planned vacation or for an emergency situation. Respite care can be provided to that individual. So that individual could either have that respite care in their home or in the home of a family member or friend, or in an out-of-home respite care setting. We have recovery management, and recovery management is the program's intensive level of case management. So that recovery manager is really going to help that individual to access all their needed services that they would need in order to be supported successfully in the community. So that could be any HCBS AMH services, as well as any other medical, social, or other resources that they might need. And then lastly, we have flexible funds, and that's money that we have that we can utilize to support individuals who are indigent, or who may have a temporary lapse in their Medicaid due to being rehospitalized. I'm going to briefly talk about our billing and rates. All of our enrollees are served through a fee-for-service delivery system. So what that means is providers will actually bill DSHS directly, not Medicaid, and providers will bill for each service provided individually to that individual. We do have our billing guidelines located on our webpage, and that link is provided there, so you can go in there and see the breakdown of all the billable services and any limitations associated with them. And also we have our rates posted on HHSC's website, and the link is there so you can go in and look at all of our rates. And next I want to just briefly outline the different provider roles and responsibilities. We have two separate providers within this program. We have the Service Provider Agency, which provides the comprehensive service array. So that means we have 19 different services in this program, and of those 19 services, the comprehensive service provider provides 18 of those services. So their job is to ensure that all those services are available to all the individuals that are enrolled in their service region. These services can be provided directly through direct hire staff, or they can be provided through a combination of directly and subcontract agreements with other service providers. And then, as I mentioned, we have two service types. We have the recovery management entity as the second type of service provider in this program. And again, the recovery managers provide that intensive level of case management. Every individual that comes into the HCBS AMH program will be assigned a recovery manager. Not actually assigned, they get to choose their recovery manager. And that recovery manager is going to help and support that individual through all the different aspects of their recovery process and tenure within the community. So the recovery management entity is also going to be providing some residential services while that individual is residing in the state hospital. So for any individual that's referred and successfully enrolled that's coming from the state hospital, we offer transitional services, which basically is the recovery manager going into the state hospital for a duration of anywhere from 3 to 6 months to really help ensure that that individual has a smooth transition into the community, as these individuals have spent a lot of time within a state hospital system and they may not have the skills needed or in place so that they can be successful once they transition into the community. So that recovery manager is going to work with them. They're going to identify if there's any other services, such as maybe psychosocial rehab, that needs to come in for that skills-based training to help prepare them for that transition into the community. And now I'm going to pass it off to Kristin, and she's going to finish off the webinar for you guys. Thank you so much.
So Amy spoke about the service provider and the recovery management roles and responsibilities. And so in order to apply to be either the service provider or the recovery manager for our program, or both, you would access our open enrollment application. A link is available on this slide, and all questions related to the open enrollment application would actually go through procurement and contracting services. So they end up forwarding those emails to programs, but any questions about the actual application has to go through them first, and their contact information is listed on the slide. And so I'm going to talk a little bit about the individual recovery plan. So as Amy talks about, that recovery manager is really that key point of contact for that individual in monitoring and coordinating all the services the individual will receive while in the program. And the recovery manager works together with the individual on any of the providers and natural supports that the individual has identified as wanting involved in the recovery planning process. And they all come together and they develop with the individual what's called an individual recovery plan. And that individual recovery plan is the document in which all the individual's goals, their strengths, their barriers, and all the services that need to be put in place for that individual in the program is going to be documented on that individual recovery plan. And the individual recovery plan and service provision through the recovery manager and the comprehensive provider is going to be employed using person-centered recovery planning. I'm sure many of you might be familiar with that process, but it's really that shift away from that traditional treatment planning approach that is often really deficit-based. In contrast, PCRP really empowers that individual to be a leader in their own recovery. So for them to really formulate the goals that they want to work on, and then that recovery manager and other providers are available to offer that individual support and help them navigate the program. All providers in our program are going to have the opportunity to participate in person-centered recovery planning training. So we have both online and in-person modules. We've partnered with Texas Mental Health Resource, also known as Via Hope, and so they're going to be providing ongoing training for our providers to make sure that PCRP is utilized effectively while working with participants in our program. And so I'm going to shift gears to talk a little bit about the HCBS AMH setting requirements. So the setting requirements are passed down by Center for Medicaid and Medicare Services, and what they refer to is the settings that an individual can reside in when receiving HCBS AMH services. So these settings ensure that the individual is really fully integrated into community and receiving services in a home and community-based setting. So some settings that would meet these requirements would be an individual's home, apartment or a family apartment, assisted living facility, and some smaller community-based residences. Some would not meet the setting requirements are a nursing facility, institution for mental disease, or any other facility that has the qualities of the institution and that serve to isolate the individual from the community. And so any place where an individual receives services must meet the setting requirements, but then there's some additional layers for those provider-owned and operated home and community-based residential settings. So where an individual lives, they must have a lease or a tenancy agreement that provides the same rights and responsibilities that you or I would have when leasing an apartment. And then also the individual has to have privacy in their living unit. So they have to have lockable doors and a key to their room, of course. And then they also have the freedom to choose roommates or also the freedom to furnish their own living environment. And then the individual must be able to control their own schedule, including access to food at any time. And then also the individual must have the freedom to have visitors within their setting. And of course, the setting must be physically accessible to the individual. So what these setting requirements serve to do is really to integrate that individual fully into the community, encourage them to have as much privacy and freedom as possible, and to kind of live and experience the community like you or I would. And the setting requirement is based on individuals' needs and the resources available. And also, the setting must ensure that the individual's health and safety is taken into account. And so I've provided a link to the setting requirements through Center for Medicaid and Medicare Services, and that kind of outlines it more in depth. And then also, any interested in providers, interested in providing some of the residential services, can use our checklist, which is available on the link on this slide to our website. It's under the Settings tab, and an interested provider can go ahead and use this settings checklist to look at their facility and see where they are in meeting these setting requirements. And then DSHS is available to provide ongoing technical assistance. And so we understand that in order to ensure an individual's health and safety, sometimes modifications to these settings will need to be made. And so these modifications will be, to any setting requirements, will be listed on an individual's recovery plan. And so setting requirements that could be modified include if the individual's needs limitation in terms of access to visitors. So maybe there's, based on some supporting documentation, that it's within the individual's best interest to have rules and regulations around those visitors. That could be listed as a modification on the IRP. Individuals' privacy in their living environment. Maybe that individual needs staff to have a key to their door, then that would be listed as a setting modification. And then also if an individual's schedule needs to be modified, maybe they need to have someone to go with them, or they need to notify appropriate staff before they leave the facility to ensure their health and safety, that could also be listed as a modification. Any other modifications necessary to ensure health and safety of the individual, other residents, or staff would just be documented in that individual recovery plan. So it's just really key to just document the necessity for those modifications. And then I'm going to shift gears to talk about our HCBS AMH provider type. So we have a provider, our program has a provider type available through TMHP. So what that does is that allows any interested providers that do not have a current Medicaid number, they are then eligible to apply for our open enrollment. And so any interested applicants applying for to be providers in our program, they could use their existing Medicaid number, or if they don't have an existing Medicaid number, they can go ahead and submit their open enrollment application. Once they, an applicant would pass our credentialing process, meaning they their application meets our desk and our site review, then they could be issued a letter which credentials them to become a provider, to receive our provider type within our program. And that letter would be submitted through TMHP with their application. I've provided a link to access the TMHP application, and then if there's any assistance needed for that applicant to complete the TMHP application, I provided the contact information to access TMHP representatives who could be helpful in completing the application. Okay, and then to talk about just where our program is to date, and to recap, our program has been got CMS approval. Our state plan amendment has been approved October 13th, 2015. We currently have open enrollment applications coming in, and any applicants are eligible to apply currently. Now, we understand that sometimes for the comprehensive provider piece, maybe that a potential applicant is interested but can't provide all those services. So it's important to network with other community providers to potentially see if there's someone that wants to step up and take that role as a comprehensive provider, and then subcontract with other community providers available. And then HCBS AMH expansion criteria has been defined for our program, which Joy talked about earlier. And what this allows providers to do is it increases their choice in the populations they want to serve for our program. So that's exciting for potential providers. And then next steps for our program. So we're routing the amendment to include our expansion population. So we're routing the amendment to our SWA for formal approval. And then until we get formal approval to serve that expansion population, we'll be providing services to them through general revenue. And then we're looking at developing partnerships. So as I talked about, networking with community providers to see who wants to step up and potentially apply and subcontract with any community providers to provide these HCBS AMH services. And any interested applicants can receive additional support from Texas Institute for Excellence in Mental Health. So we partner with them to help applicants in implementing the program, the HCBS AMH program. And the contact information for these for the representatives you can contact at TIMH is listed on the slide, and we'll be sending out this PowerPoint after the presentation. And then we have some upcoming events. Tomorrow we'll be doing a provider forum in San Antonio, which will kind of be similar to what we spoke to you about today on the call. And then we're having additional forum dates to be announced in the spring in different areas. So if you are interested in kind of coming out, learning a little bit more about the program or meeting us in person, that would be great. You can contact Amy Pedersen, who her information is listed on the next slide, about being added to our distribution list, and that will give you an idea of when upcoming events for our program will be. And so our contact information is listed, and again, I'll be providing this PowerPoint after the call. And so that is the end of our program. End of our presentation. And I think we can open up to questions now. I'll turn it back to Jason.
Yeah, thanks. Wow, that's so much great information. It's going to take me a while to process everything. But as a reminder, folks, if you want to ask a question, let's try using the chat box. It's going to be in the lower right-hand corner. Just type in your questions, and then we'll read from there. But I'd like to kick it off. I've got two big questions. One is that I'm really excited that y'all are expanding the populations to the 3. I think that especially when we start going into jail diversion and ER, many of us know individuals with co-occurring issues that you described. And these individuals have really high needs. So I'm glad to see that there's a whole host of kind of wraparound or support services that can be offered, employment, meals, peer support, transportation. But the setting requirements is what makes me nervous, because the setting requirements sound very much from a kind of mental health housing perspective, and doesn't necessarily represent the evidence-based practices around recovery housing that we see on the substance use side. One example would be there's research that shows that occupancy rates of 8 or more in recovery homes generate better outcomes than 7 or less. And so could you talk to us more about, so what does that modification process look like?
Mm-hmm. So, it's really based on ensuring the individual's health and safety, and also it's based on their choice as well. The individual has a choice of where they'll receive services. So, and those combined aspects of it will really inform what modifications need to be made. So, for example, if an individual would want to live in a recovery residence, it would just need to be really documented on the IRP why the structure of the recovery residence would best meet the individual's needs and really support them in their recovery.
Got it. And so that's that. My first question was really about how providing these recovery support services in the setting, and just being able to provide them at all within the setting. But then earlier on in the presentation, I believe you all listed 4 different types of housing that could be reimbursed, or at least that's how I interpreted it. There was host housing, supported home, supervised and assisted living. None of those sound like recovery housing. So can recovery housing, the housing portion of what we provide, be paid for through this funding stream?
I think that's what we wanted to get a little more nitty-gritty on the second series of this, because we wanted to look at in line with everything that is paid for. But if we want to take a minute here, if you want to review what would fall under what your folks do in a current recovery housing model that would maybe fit in line with some of these service descriptions. So would they assist someone with, if they needed prompts to do ADLs? I mean, I know there's definitely a strong social component, so that's already built in. But I guess I'm just trying to parallel what it is and how that could work, or if we need to look at compromise on both ends to see if it would meet the definition requirements. So.
Yeah, that's I think I asked a really big question, so I apologize. I don't see any chat. Let me see if I can open the lines up.
Out here, it's just put your face on somebody else's head.
Kristin, Amy, and Joy, I'm not hearing any other questions. Y'all mentioned that there'd be a possibility for us to have a second webinar that could maybe unpack the issue that I was talking about, or the question that I had.
Sure, yes. We wanted to do a follow-up to really touch on more specifically the setting requirements, how it relate to recovery residences, and then also see kind of where recovery residents might fit in terms of our residential settings services.
Yeah, we'd like to do like a side-by-side comparison of what that would look like, you know, what's provided currently and how that might meet these standards and how we could partner and move forward. But we wanted to have some time to get some information really specific on what would work and what potentially would not.
And then, of course, after this call, if any of the providers on the line, if they have any feedback or anything they really want us to explore in terms of when we talk more specifically about that housing piece of it, please feel free to email us because we can include that as part of the follow-up webinar.
Absolutely. And so one of the things that I can do is after this share the slide deck with everybody who was on the call today. The slide deck included contact information. Please email us with your questions and comments, and I'd be happy to sit down with y'all over the next month and help develop that side by side to see where the potential is, because this is there's a lot of people within these high needs populations that would be interested in recovery housing, and so finding ways to at least make that an option for them is important to me.
Yeah, definitely, and it's important to us as well, which is why we'd love to partner with you. And it's a lot of information today. That's why we wanted to kind of break it up into two parts to kind of give a general overview of the program and then kind of map out how the pieces can intersect as we move forward.
Well, one last chance for anybody to ask questions or submit questions. Let's see. I don't see any questions in the chat box. So if nothing else, then I guess we'll sign out for today and be looking for an email from us about that includes the content from today and contact emails, as well as an invitation to join us to continue this conversation sometime next month.
Yep. We're looking at April 4th as the next follow-up webinar presentation.
Perfect.
Okay,
well, thank you to our presenters today, and thank you for everyone who attended. This is definitely exciting to start looking at opportunities. Historically, recovery housing has been limited because it's been a kind of a pay your own way way of accessing housing, and that's very important to have people engaged and have purpose. But there are barriers for many people that need help getting in recovery housing. So again, thank you everyone, and be looking for the emails. Thank you.
Thank you everyone.
Thank you.